Welcome to the world of anaerobic infections. This is super cool topic. More probably relevant like in science too and like real life. Not so much for your boards. It's not a whole lot of bugs there that are good testable. But right, so anaerobic infections, there's more anaerobes in our body than aerobic. They are part of your normal human microbiota. They mostly stay in your mucosal surfaces, so that's right here, right, mouth, your GI tract, and for a female, the GU tract, right? It's and the infections actually occur when there's that just generally when there's breakdown of those normal barriers. That's and you have that leakage of your indigenous flora to your bloodstream, causing bacteremia and other stuff. So the hallmark of anaerobic infections are polymicrobial, right? Because again, you're kind of leaking into stereocytes and formation of abscess. So anaerobes, we just talked about in our first question that you couldn't see, requires reduced oxygen. For growth, that's really like how much oxygen. So how much oxygen is in our regular air right now, 21%, right? And these guys, like how much? Less than like 1% of oxygen. Yeah, so super anaerobic condition. So several species that forms your microflora are inhabit strictly anaerobic conditions. So, so wonder why, like, right? So it's kind of difficult to culture them. And again, yeah, requiring very, very low reduced oxygen. So some of the species that actually do cause infections that we are able to pick them up in the blood cultures are actually kind of quite aerotolerant. So like 2 to 8% is when they can grow. So but the rest of the majority of the species, they cannot survive. Okay, so anaerobic bacteria of medical interest. Give me the bugs. Give me the bugs. What is your spore forming gram-positive rod? The very first one? Clostridium, excellent. Clostridium species. Is there a spore forming gram-negative rod? Trick questions. There's none. Okay. Give me your gram-positive non-spore forming rods that are of medical interest that you guys have heard of. Bacterioides versus gram-negative, right? Oh, nasty headache. Listeria is aerobic. You guys, again, just had aerobic lecture. Forget about aerobes. Think about it. Lactobacillus. Thank you. What else? Actinomyces. Thank you. What else? There's lots more. Right, so Cutibacterium, Bifidobacterium, Lactobacillus, Eubacterium, Actinomyces. Certainly you guys have heard of some of those names. What is your gram-negative rod? Bacteroides. And what else? Mouth. Fusobacterium. Thank you. Gram-positive cocci, Peptostrep, Peptococcus, and gram-negative cocci, anaerobe, also part of your flora in your mouth. It was in one of the options. Veonalia, thank you, Veonalia. So yes, remember these bugs when you guys get that phone call from lab. Hey, it's growing only from anaerobic bottle. It's gram-negative this, gram-negative that, but it's anaerobe. So you gotta be thinking about these bacteria because some of them may not be covered by your empiric Fengsos and Feng-Cefepime regimens, right? Okay. So which body site? I'll just ask you guys, which body site has more anaerobic than aerobic flora in general? GI. So we said GI. What else? Mouth. Specifically where in your mouth, right? Because it's just open, right? So it's, it's like open to air. So where? In your plaque, so gingival crevices, right? So that tiny portions of our mouth, those cracks and crevices, that's where they stay. Where else? One more? Females, GU tract, female GU tract, okay? But generally, again, just very generally speaking, again, there's way more anaerobes than aerobic ratio. So over really 99% of our body is made up of anaerobic bacteria. So, right, so in the upper airways, in the nasal washings, again, you see the total bacterial number per gram per ml. And this is, as those of you guys rotated with me at Moffitt, I mentioned this. So look at your GI tract, right? Your terminal ileum and colon, right? That's like the most concentrated total bacterial number. And look at that compared to your gingival crevice. Gross, right? Gross. So that gram of stool compared to gram of your, let's say if we are able to get a gram of your plaque, that's you have pretty much equivalent, number of bacteria. Gross. So get your teeth cleaned. You have good dental insurances. Get your teeth cleaned. But again, yeah, looking at aerobic ratio, you see there's way more anaerobes. So what's in the upperware? What's in your saliva? Mostly predominant organism in your saliva. We see Veillonella, your gram-negative cocci, also along with some gram-positive cocci. What's along your more, again, coming down to more anaerobic conditions, down to your gingival crevices? What do we have in our mouth? Anaerobes. Peptostrep, you mentioned, Prevotella, thank you, Porphyromonas, Fusobacterium, Bacterioides, we also have in our crevices. Going down, you see in the stomach, there's not a whole lot of organism that can live in that environment, right? Because your pH is like 2, right? So there's not a whole lot. So whatever you have here, going down to the stomach, gets cleaned up and then gets restored, passing your jejunum ileum and have another flora living down there. Right? So because of low acid, again, way down to your colon, what do we have down there? What's our flora? Yes, same. Like more or less same here in the upper GI tract, but what was it? Enterobacteriales, right? And those would be more aerobic, but your anaerobes would be again going back to like your Clostridium, right? Your bifrag, your Peptostrep, Fusobacterium. And there's separate and another whole flora down there in our female genitourinary tract as well. Okay, and of course, we understand that our microbiome is different amongst all of us. It depends on geography, location, and your diet, etc. Right? Okay, so, and I thought this was a super cool chart, super cool graphic of what we actually have based on different genera. So the left side you guys see are your bacteria species, and the right side is your microbiome, so your fungal. So what do you have? So on the left side, you see a lot of these greens, right? Those are called firmicutes, and those are the light green you guys see on the left side that we have a lot in our oral cavity, esophagus, vagina, and the colon. The firmicutes are everything that we just mentioned, like lactobacillus, lactococcus, also including some gram-positive, like your staph and strep, listeria and bacillus as well. What else do you guys see here? You see in the stomach, right? We said there's not a whole lot of things that can survive there. In stomach, that light blue color proteobacteria are like your gram-negatives, the Helicobacter, enteric E. coli that you mentioned, Salmonella, Shigella, guys. And looking to the right side, so again, we are colonized with lots of microbiome as well. What's predominant on our skin? What is that purple you guys see? Can you see it? No. Malassezia. Yeah, it's the predominant microbiome that we have on our skin. And yeah, Malassezia, perfect, exactly. Yes. Okay, excellent. So there is this concept, this beautiful concept of colonization resistance, right? And this is the reason why we got to kind of try to work on. There's a lot of research going on the last couple decades on microbiome, how it affects your health, how it's related to a lot of diseases, and even affecting your brains, right? Because the presence of all these anaerobes effectively interfering with colonization by potentially pathogenic bacterial species. So easily put, right, in C. diff infection, we kill all of our good microbiome, and your C. diff spores, they germinate, they produce toxins because you don't have that nice colonization resistance by your other microbiomes. And for example, too, why and how the fecal microbiota transplant works is super fascinating. There's a lot of basic science that goes behind it. For example, did you know your Bacterioides, that specific Bacterioides species, stimulates the mucosal cells. They produce certain lectin and certain chemicals to actually kill your gram-positive. So really cool stuff. Some of those interesting papers that we gotta know and think about. This is from Fred Hutch by Dr. Frederick's lab. back in 2017, looking at like weekly stool samples on patients who have undergone transplant and kind of correlating that to the severity of acute GVHD. So a lot of issues coming up. Let's say, the more, again, we understand the more anaerobic antibiotics that we use in our patients with who's undergone transplant, they tend to get more, again, graft versus host disease. And in other outcomes as well, right? Like community onset bacteriomic biliary tract infections. Certainly we see that a lot of Moffitt, right, with your cholangitis patient, biliary issues, people with stents, I think our current still practice especially from the general internal medicine side, is like kind of empirically covering for anaerobic organisms, but do we really need to, especially if you don't find them in our cultures? Yes, we understand anaerobic is a big part of the flora, but if you see E. coli growing from the blood culture, does that patient really need metronidazole? I don't know, maybe not. And also looking at even, just like in critically ill patients with anaerobes, and really kind of, again, being that steward that we are with antibiotics, and being very mindful of the entire microbiome that we're killing with our anaerobic coverage. Okay, so, right, and this is what happens, right? If you give antibiotics and probiotics at the same time, it's like, what are we really doing? And also, again, kind of trying to save your microbiome. Okay, so anaerobic infections, of course, it's implicated in many different areas. Again, kind of thinking about where your most anaerobics are located, right? Again, we talked about upper mouth and head and neck, going down to the thoracic cavity if you like have aspiration pneumonia, and that turns into kind of more chronic, like long abscess and pyema. Is probably more than, let's say, just like one-time aspiration. Do we really need that coverage, right? And of course, going down all the way to abdominal cavity, again, any break in your mucosal barrier, you're going to leak that flora in there, including, of course, female genital tract. CNS infections, really not so much from, local flora, but maybe, if you have issues going on with your sinuses, that will kind of directly inoculate. Or there have been cases also of embolic, diseases, let's say from an endocarditis, traveling to the brain. Skin and soft tissue infections, you guys see a lot at the VA and over here as well. Okay, what am I looking at here? Okay. So give me your clinical diagnosis of this patient with gum bleeding, has very foul breath, bad taste, and could also become quite septic. What is your clinical diagnosis? This is
gingivitis.
Very bad gingivitis. There's a term for it. Necrotizing gingivitis. This is called trench mouth or Vincent's stomatitis, right? Yeah. And if it gets worse, that leads to like necrotizing infection of your oral mucous membrane, gingival inflammation. I mean, at this point, you will have like orofacial gangrene. This is really, you're gonna only see this in really young children in sub-Saharan Africa with severe malnutrition, and this is called what? Anybody? I know Divya got this because when I gave the clue, so the name is the same name as the world's restaurant that has 3 Michelin star that is now turned into a food laboratory in Sweden, right? In Sweden? Yeah. You guys know? Any foodies here? My foodie? Noma. It's called, yes, thank you, Cancrum oris. Yeah, not separate from the restaurant, but it's the same name, Noma, Cancrum oris. So, again, yeah, if you don't take care of your mouth and you have malnutrition, it can go as bad as that, right? Insane. Okay. It's actually not. I guess it could turn into one, but it's just your anaerobes eating up your gums, and turning into a necrotizing infection. Yep. Down to osteomyelitis, of course. Yeah. So what is this? So this is more relevant here. We've certainly have cases here at TGHVA, probably not so much Moffitt. So you have sublingual, yes, thank you, sublingual, submandibular spaces, right? Coming from your gingival infection, going down, swelling, coming in with chest pain. But you look at the patient, it's all red here. Swelling of the tongue, potential airway compromise. This is called Ludwig's angina. Thank you, as Curtin said. What is this one? Yeah, and certainly cases have been missed as a cardiac issues, but it's really an infection. What is this one? So we have Lemierre's. Thank you. What is the bug? Usually Fusobacterium, but it can be with any other, really any other anaerobes, also including like Staph aureus, Echinella, Streptococcus peptostrep, Porphyromonas. So what do you see what's in the CAT scan? Septic pulmonary embolism down to the lungs, because knowing your anatomy, right, from the IJ drainage, kind of, again, going to the lung. Yep. Okay, excellent. Okay, so aspiration pneumonia, aerobic or anaerobic? I know this has been a big question the last couple of decades, so I have a really bad headache. I think it's the match. Next time I won't present on match day. Note to self. It's like really bad. At noon, yeah. We sent you guys the invite, so yeah. Okay, so the anaerobic coverage for aspiration pneumonia, right? We know that's outdated practice, but back in the day, just not too long ago, just 2 decades ago, in 1998, the IDSI guideline, actually, it wasn't part of the guideline that made to suggest that with patients with high risk for aspiration, maybe empiric coverage is recommended, but that recommendation was based on some observational and case series studies. But again, now knowing more science and data to back us up, so this first paper is from Japan, looking into about 300 patients with really severe pneumonia and patients who had increased risk for aspiration. They basically did like bronch cultures, even direct transthoracic drainage, because some of these patients had like empyema, lung abscess. And looking at their cultures, what do you guys see? It's really, this is again like community-acquired lung abscess. It's a lot of aerobic and aerophilic streptococci to be the most common cause of pathogens, almost 60% of the pathogen. Anaerobic being the second most common, so I'm not saying it's not there, but your most common is actually still your aerobic and aerophilic strep. Another study on the right, looking at long-term. This was at University of Buffalo, looking at long-term care facility patients with severe aspiration pneumonia. All of these patients had bronchoscopy, and looking at those organisms. Interestingly, half of them was gram-negative rods, like E. coli, Kleb. Gross, right? So like coming from the gut, like all the way down to the gut, aspirating into your lungs. So not so much, again, anaerobes, again, like maybe second highest, 16%, but also interesting, Staph aureus, a tenth of them. So again, probably upfront, not really needed unless you actually proven, okay, this is a lung abscess and there's an empyema that's probably sprung from aspiration. Yes, maybe consider it, but obviously you have to have your cultures to guide your therapy. Okay, how are we doing with time? Okay. Real case, guys, not a question on your phone. So we have 56-year-old female. I think I had it with either Celia or Hannah when they were interns. So 56-year-old female with uncontrolled diabetes and recently diagnosed lung cancer is admitted due to fevers and some like vague abdominal aches. You examine her, abdomen feels soft, labs with mild leukocytosis, lactate was 2. CT without contrast shows some just vague diverticulosis. And the blood culture returned for Bacterioides fragilis. Okay, so you initiate treatment for possible diverticulitis, right? But on day 3, you're treating her. Day 3, day 4, like every single day. Oh, not every single day, sorry. 48 hours. You're culturing. She's still bacteremic day 5. What are you guys thinking? What do we do now?
Abscess.
I
think that there's an abscess.
Okay. Great thought. What should we do then? Scan her. So we scan her ideally with contrast, right? So you got to give her oral contrast and also IV contrast, right? To really define your even small abscess. If there's a perforation, ideal, at least give them oral contrast, right? And I didn't say she has any kidney issue, so there's really no reason why we would not scan her without contrast, right? So we get the CAT scan. It still says like diverticulosis. Great thought. Yes, certainly there have been cases of Bacteroides fragilis specifically that are resistant to which drug? Metronidazole too, and beta lactams too. But yeah, so then you gotta ask, okay, can we send it out for susceptibility testing? But also it's depending on your hospital. But this was TGA, so we have this we have the susceptibility. So it was susceptible. So what's the issue? What are we missing? Because abscess is a great thought. Great thought. Yeah, you'll be looking at other spaces. Malignancy, like tell me more. Like what do you mean malignancy?
Like a colon cancer, like a.
She has lung cancer.
Oh.
Yeah. Australia has lung cancer. Yeah.
Yeah.
Excellent. Yes. Yes. Right. So we ruled that out with a CAT scan. It just says diverticulum and no perforation. What else could be hiding?
Like a post-obstructive pneumonia from the lung cancer?
Oh, thank you. Yes. Yeah. Great thought. Absolutely. But she had no respiratory symptoms. And her mouth looked fine.
Colonoscopy.
Colonoscopy, good thought. But obviously we can't really get a colonoscopy in the hospital unless there was some signs of, let's say, colitis, or she has profuse diarrhea, right? That would make us, ask the GI doctors to at least get a sigmoidoscopy. There's something going on, but she didn't have that. She didn't have diarrhea. She didn't have nausea, vomiting. She just had vague abdominal pains.
And there was no mass, no like metastasis,
Right.
scans.
Nothing. Yeah, nothing.
Echo?
Okay, oh, good thought. Absolutely. Right. Like she's persistently bacteremic, right? Like, kind of almost doing FUO workup at this point. Yes, we'll get an echo. So, like maybe she has endocarditis at this point. She's been bacteremic for 5 days. I believe her echo was clean. Yes, her echo was clean. Right upper quadrant ultrasound didn't show anything. All within normal limits.
No lines.
No lines. Good, very good thought.
No hardware.
What was that?
Oh,
No
you're right,
hardware.
Any biliary?
Great thought, but we did a right upper quadrant ultrasound, no obstruction.
CT maxilla for periapical abscess, like a dental abscess.
Fantastic thought. Her again, she had like no oral symptoms, but I actually don't remember if we scanned her face for dental abscess. But that's a great thought, right? Because we do have Bacterioides in our mouth.
What about like perirectal abscess?
Right. Yes, perirectal abscess, great thought. But again, remember we just had CT abdomen pelvis with oral and IV contrast that did not show any abscess anywhere.
Yeah.
It would have shown in the I like this. What are we missing?
Can I do that?
David's gonna ask ChatGPT. Okay, so what do we do? So we are, and I had the whole team, right? Like a junior attendants, like, what do we do? I was kind of desperate, a little bit desperate, because like we couldn't find the source. Right? It could just be just like this diverticulosis that's causing this, causing bacteremia for 5 days straight on right therapy, and ruling out, resistance. So I brought the whole team down to the radiology lab. We took a field trip. What's that? Certainly, and that's why I think Dennis brought up like tag, WBC scan, kind of looking for the source or any sites of inflammation at that point, right? So we went down we took a field trip to radiology suite because I wasn't convinced, like there's something missing here, obviously, and I found another attending and begged him to give me a second read, and the second read came back as SMA thrombosis.
Oh.
So she had a clot in her GI tract. And we gave her anticoagulation. She cleared. So moral of the story, don't always, if your clinical scenario doesn't fit with your data, like, again, the radiologists are humans too, right? So you can always get a second read, bring the whole team down, get a second read, because, you're certainly missing something here. So they can hide. No, I didn't get it again. It can hide in your clots, okay? So so clots. So and you mentioned about the septic embolism, endocarditis. These are great thoughts, but again, looking at locally, and she had the risk factors, right? She has diabetes and she has, recently diagnosed lung cancer. So it was a clot at a very weird spot that was giving her an SMA. Very weird, right? And with the vague abdominal pain, right? Like, what's that?
Pain with eating.
No, she didn't. She didn't have any of those. Yeah, it wasn't something chronic, so it was something like pretty acute.
She didn't
Yeah.
have any like
She had no bowel issues. Nope, nothing. Yeah, no ischemia. Yeah, it was pretty acute. Yeah, yeah, very crazy. It's like Bacterioides. It's like, what is going on? Yeah, not even like no E. coli, no cleft, just Bacterioides. Very cool. Yeah. Okay. So diagnosis, they are difficult to culture. Most of the colors that I showed you a while ago with the microbiome and microbiome really, we can't really culture them. These data are based on your 16S RNA sequencing, just like, like same test. Some of the test was done with us using the same technology as your Carius test. You guys know Illumina. Time consuming, misleading. So again, kind of going back to our table, those are really the more medically relevant infections. Though all those guys are more, again, aerotolerant, right? Like able to survive between 2 to 8% of oxygen. Again, thinking about those sites, tissue necrosis, abscess is the hallmark, again, of anaerobic infections. If you start smelling foul odor, certainly, we've seen those patients with like oral cancers, right, on Moffitt with really bad infections, tumor, necrosis over time. They tend to become very foul odor. And patients with lung abscess, of course, as they breathe, you can kind of smell it. It's really bad. Those are all late signs. And also thinking about anaerobic infections in patients that are failing to respond to antibiotics, and you look at your regimen, you don't have, regimen that is active against anaerobes, maybe think about anaerobes. And especially when we poke abscesses, we drain them, and then you look at the gram say it says it's polymicrobial, but when you actually wait for culture, 3-5 days later, nothing grows. What does that mean? Maybe it's all your anaerobes that died and that you weren't able to culture, right? So sterile pus, right? Think about anaerobes, or with failed collection and identification methods. Okay, so and this is more or less easy for you guys because we have really a few of our antibiotics that are highly active against your anaerobes, right? So thinking about your carbapenems, and metronidazole, your beta-beta lactamase inhibitor combinations, and chloramphenicol not so much because of toxicity, bone marrow toxicity. And then variably active, we sometimes use, right, like clindamycin. Cefoxitin is still a #1 choice for our OB folks for their GU surgeries. High dose penicillins, tigecyclines actually has also good anaerobic activity. Yeah. Okay, and not so much, right? So not so much, because we can have variable resistance with our good old penicillin, cephalosporins, vancomycin, is also again active against some gram-positive anaerobes, but not, but it will be inactive against gram-negative. And no, we wouldn't really use these for anaerobic coverage. Okay. Moving on to a slightly separate topic. What do you guys see? So the first picture is neonatal tetanus in developing countries, right? It's usually, we don't really see it now, but it's failure of aseptic techniques while we are, and inadequately immunized mothers. What's the second picture there? What is that physical exam finding? That is called, starts with O. Opisthotonus, thank you. It's because of generalized. Oh, welcome. And the patient here is conscious or unconscious? What's that? Conscious, right? So it's like super. Yes, exactly. And because it doesn't affect your CNS, it's autonomic hyperactivity. Okay. Mortality. Tetanus, over 90%, right? Over 90%. Thank you. So that is tetanus. So by your spore forming gram positive rod, Clostridium tetani, right? So it is obligately anaerobic gram positive with a terminal spore. So it looks like a Tennis racket, thank you. You'll see the pictures in your boards. Of course, it's toxin mediated. In the United States, again, kind of watch out for, patients with waning immunity. So those are older, elderly patients. But I guess, I mean, even in kind of general, if they don't see their PCP for over 10 years, they're not vaccinated, right? High risk wounds, puncture wounds, gunshot wounds, burns, compound fractures, contaminated injections. Our ED is like really fantastic giving tetanus shots, but be wary, if you see these patients in the burn unit and then you ask, you're looking for tetanus vaccine history and you don't see them, probably best to give them tetanus shot. Okay. History exam is the diagnosis, right? Because we can't really culture these organisms. This is a toxin-mediated disease. Probably, again, kind of you have to really think about in a patient who hasn't been immunized and, has some sort of wounds and is going into sepsis and all that, like rigidity, right? So treatment, ICU, of course, airway, benzodiazepines. There's a debate about using flagyl to actually kill the organism themselves. There's mixed data. It's not really black and white. Yeah. Prevention, vaccine, of course, we know. Okay. And especially in our Moffitt patients, right? Bone marrow transplant, after bone marrow transplant, they get all their routine vaccinations. Make sure they follow those and have those vaccines ready. Okay. Other Clostridial infections, the scary ones, the scary toxins. The next question is, I'll just read it to you. Which Clostridium species produces lecithinase? What is lecithin? So lecithinase is something that will degrade lecithin. So what is lecithin? It's fat. It's a mixture of fat that's in our cell membrane, right? Cell membranes, right? Yeah. So what was it? Excellent, right? So the infection that would cause like necrotizing infection, right, is perfringens. So that would produce lecithinase. Okay, lecithinase. You can see that. What about which Clostridium species produce enterotoxins? Difficile. What else? Bless you. Not tertium. I think what is here? So, let's see. Enterotoxin. But septicum. We'll see. But not. That would be next question. Neurotoxin. So botulinum, sorry, perfringens. 2. Yes, also. Neurotoxin, right? Yeah, GI from, eating bad stuff. Okay, neurotoxin, we said, and tetany, right? So Clostridium tetany and botulinum. What about proteases, histotoxins, and hemolysins? All of them can produce them, all the species. So, right, again, understanding there's many different Clostridium species. You have, and I have, here, okay. So lecithin, again, thinking about if you're seeing a patient with necrotizing soft tissue infection, perfringens, Sordelii. I think somebody mentioned Sordelii has been implicated in what? You guys remember? I'll show you. Thank you. Yeah, GU, female GU tract. Enterotoxins, you have perfringens and difficile, and neurotoxins down here with your botulinum and tetany. Excellent. Okay, so myonecrosis, right? Gas gangrene, again, kind of thinking about in our patients who had really traumatic crushing injuries, penetrating trauma that creates that kind of low oxygen environment for the Clostridium to thrive. In patients with GI, again, GI biliary tract surgery, septic abortion, thank you, that was Clostridium sordelii. That can be in your boards. Prompts, again, these patients should be on the OR table like yesterday, right? And along with antibiotics, yes, amputation, hysterectomy, and debriding, and getting rid of that low tissue oxygen environment, right? So lots of toxins, yes. And of course, gas gangrene, they should be in,
Pig bell
syndrome.
crushing.
Like this?
Pig bell, yes.
Pig bell syndrome.
Like necrotizing GI.
Oh. Pig bell syndrome. Okay. So can cause bacteremia. Again, thinking about those microflora spaces, your biliary tract, female GI tract, perforagens and sordelii implicated in postpartum, post-abortion infections, pleuropulmonary 10%, with C. perforagens being the majority. Okay, there are, let's talk about your gram-negative rods, your Bacteroides prevotella. So not, again, kind of your part of your microbiome, kind of repeating some of the things that we said. Directed by culture, susceptibility, really pretty much similar, but I want you guys to see this one. So a lot of your, again, your antibiotic that we just mentioned have good activity against all of the species except you see for Bacteroides, you know, please don't use clindamycin, and also just your good old plain penicillin, again, kind of looking at more beta-beta lactamase combinations, metronidazole. Okay. Tigacycline has also good, again, activity, but again, we've seen only really reserved for like intra-abdominal infections and not so much with bacteremia. That's not, Tiga is not your like first line choice. Okay. Your anaerobic cocci, gram-positive non-spiraling bacilli, what were they? Anaerobic cocci, gram-positives. You said peptostrep, right? Peptostrep, but there are many other things, right? Like your Fingoldia. You guys heard of Fingoldia, right? In what infections? Fingoldia magna. And right, I know we've mentioned that how anaerobic infection tend to be polymicrobial, but specifically for Fingoldia magna can be actually by itself. Brain abscess, what else? Prosthetic joint infections. Prosthetic joint infections. Prosthetic joint infections, okay? And your other, there are many, again, under the firmicutes, but we've already mentioned some of the more medically relevant species already. So give me the genus. Your highest pathogenic potential among that table that I should show you, causing skin and soft tissue joint infection. Huh? Fingoldia. Okay. This species is most prevalent in the mouth, can cause periodontitis, infect the root canals, failing dental implants. Prevotella is a good thought. What's other P? Parvimonas. Can cause head or respiratory GI. It's pretty much everywhere. Infection was peptostrep. Yeah. So if you see these guys in your culture, don't ignore them, again, depending on your site. Okay. What is your gram-positive rod that can cause infective endocarditis, aortic aneurysm, abscess, and also in foreign bodies, especially foreign bodies? Foreigny is aerobic. But you're along the line. Gram-positive rod, anaerobic. Your? I guess it could if you look at it under Gramsci, I think, yeah. It has a new name. That's because I put the old name there. What's the new name? Bacterioides. Yes, thank you, right? Yes, you know, cardiac infection, CIED. Yeah, so if somebody, so again, reversing, if somebody has like a cardiac device and you see Bacterium in your blood culture repeatedly, that's bad, right? Thank you. Yes. Yeah. So that's bad. Yeah. Yeah. So there, yeah. So you would actually treat them and not ignore it, right? Dental caries. So again, gram-positive raw, dental caries, bacteremia, infective endocarditis, high mortality rate. We can see it as also like lots of Moffitt with immunocompromised with prolonged hospitalization. That species is vancomycin resistant. So again, kind of thinking about if you see this, if you hear this from the lab, hey, there's a gram-positive anaerobic raw growing from the blood culture and the patient's pretty sick and they're on vancomycin, you're missing coverage. So what is this species? Genus Lactobacillus. Thank you. Lactobacillus. Oops, I gave you already. Oh, bifid. I was like, oh no, that's okay. Urosepsis. Have you heard of this? Urosepsis, renal stool lithotripsy, anaerobe. It's hard to culture, but if they do, from Malditov. Actinobaculum. It can be seen in gram stain. So they'll see it in the gram stain, but they don't grow. So you think about Actinobaculum, especially again in that setting. Again, but MALDI-12 16S gene sequencing can show it. I'm sorry, it's a lot of facts. Yeah. Okay. Vaginosis, Mobilincus, infected human bites, Eubacterium, or Echinella crodens too, right? Okay. So some of these species may have higher MIC, but generally, if you just give them kind of again, understanding, except for really lactobacillus probably, if you give them general, like, your piptase or your carbapenem and metronidazole, it'll work. Okay. For now, we'll see in the future with, rising antimicrobial resistance, very scary. And certainly we've seen metronidazole resistant strains for Bifidobacterium and lactobacillus. It's pretty scary. Okay. Last, I think, okay, just a couple more slides, guys. Actinomycosis. Switching gears. So what is actinomycosis? So it can look like cancer, right? So somebody coming in with a lumpy jaw, like you have some sort of mass that's been growing, or it's a draining sign of something's leaking down in your jaw and your corners over time. So it looks like cancer. So these patients will get a biopsy, right? And lo and behold, it's not cancer, it's actinomycosis. So think about patients who have like sinus tract, bad gingival infections, inflammation. They didn't, see their dentist for over years, and also has been associated with IUDs and bisphosphonates. So again, very relevant to clinical practice.
In clinical example, we had a case of a patient that she kept the IUD for 20-some years.
She had actinomycosis.
Ah.
Oh no.
Uterus and
Oh.
just it happened.
Terrible.
Really
Yeah.
bad.
Yeah. Again.
She's at Moffitt, but she doesn't even have a cancer diagnosis.
Oh wow.
So,
but again, right? Actinomyces, this is part of your flora, right? So it's sticking to something, and it's kind of, became predominant species in that, maybe that small microflora, and then kind of, flourishing, right?
So, board review question for the fellows. If you have a woman with an IUD and they do her cervical pap and actino grows incidentally in their pap smear, what do you do next?
remove the IUD.
No, nothing.
Yep.
If they don't have any symptoms, right, such as fever, night sweats, abdominal pelvic pain, you don't necessarily need to remove the IUD unless they have some.
Because again, it's part of your flora, right? So if you culture,
If it happens to 90 doctor,
right,
I
right,
say take that out.
yeah. Oh yeah, right. But if again, we gotta always be prepared to deal with the consequences when you culture non-sterile sites, right? So gram-positive, filamentous, again, these can have, again, along with actinomycosis, if there's a true infection, you can have like companion organism kind of, bringing out that flora, and that native flora. Again, think about oral, GI, pelvic, disruption of mucosal surfaces, anybody can get infected. So even though, those pictures look really bad, can look like a cancer, can fistulize and go everywhere, it's very treatable, very, very treatable with antibiotics. So again, kind of looking at the classic presentations, oral cervical, most common painless mass. And the diagnosis can be really challenging because if you biopsy, right, again, depending on the culture technique that your surgeon does, you cut it out, you put it in a test tube or container, bring it down to the lab. They're dead already, but at that point, right? So you can't really see them, and that's why, again, you can see them in gram stain, but you probably won't be able to grow them out unless you have this cool PAT slide. You can actually see the sulfur granules. Then yes, you have a diagnosis, but you still won't be able to culture them. So you have to have have that high suspicion when you see that patient. This looks like actinomycosis, and I know I'm not going to culture it out, but let's see if we can get at least some path or some gram stain from it, right? So therapy is very variable. So it's such a big range, right? It says like high dose and prolonged penicillin for 2 to 6 weeks. That's a lot of time again, but a good thing about PenG is that you can do it via continuous infusion. So great for OPAD. You just need to change a bag once a day. But again, like some patients like absolutely hate it because then you technically have to get, be connected to that PICC line and to that infusion 24/7, even though you're just changing the bag once a day. So it's a lot. And after the IV is over, then you switch them to the pills for months and months and months. But yes, the treatment is a long time, but it is treatable, very treatable, right? Again, depending on clinical experience, imaging can be helpful down the road. Again, mentioning medical therapy is usually curative, okay, even with extensive disease.
Just as like, there's gonna be patients that will not want to be hooked up for IV antibiotics for 2 to 6 weeks, so high dose of mox.
Yeah.
Like you could start
Like a
off
gram
with that,
TID,
then
no, yeah,
move on
yeah,
to,
yeah.
like, lower.
Yeah.
I don't think I've ever been able to put anyone on that long for IV penicillin.
Yeah, maybe 2 weeks I got
Especially
away. Yeah, yeah,
Unfortunately,
2 weeks, yeah.
people that tend to get this aren't the best when it comes to their health. Like the ones, I mean, like with the IVs and stuff like that, it kind of gets difficult to try to get them hooked up to that, so yeah.
But it's exquisitely sensitive, so I mean.
Yes.
High dose oral.
Yes,
Exactly.
exactly,
Like,
exactly.
This is older data too.
Right.
Yeah, exactly, exactly. Yeah,
That's a big.
exactly. That's why it's such a big range and like nobody knows. And that's why the first sentence says based on clinical experience, individualized. Okay, and that's it, guys.
There's a term for when the pus and the animals are draining out of skin. It has no respect for facial planes, right? That's the thing about Actinomyces, and then eventually it'll come out on the skin because
It's like creeping out of you. Yeah.
So there's a term for not clinical term called empyema necessitatis, which means it's draining out because that's the path of least resistance. We also had a guy from Honduras a few years ago who had like hepatic and pulmonary, like hepatic actinomycosis, where
My head is
Like,
exploding.
weight loss was being worked up for malignancy and had empyema thoracis, and eventually it drained out of his abdominal.
Yeah, you'll see,
Hmm.
you'll just want to get out anywhere. It goes everywhere.
And that's it. Any questions? Sorry, that was a lot of facts and names and numbers, but well, no, mostly facts and names. But yes, you need to know the names, and especially, like I think you'll appreciate it when you get that phone call from the lab and say, "I'm seeing gram-positive cocci, and it's only growing from anaerobic bottle. What is it?" Yeah, or that gram-negative rod. It's only anaerobic bottle. Bacterioides, right? Like so, yeah. So you got to make sure you have the right coverage for your patient. What's I think again scary is if you have a gram-positive rod and that's anaerobic and your patient's super sick and you're thinking lactobacillus, like what is your coverage? Yeah. They're on like benkencephalin, so you gotta switch them. Yeah. Penicillin, exactly. Yeah. Okay. All right, thank you.